Welcome, everyone. This is Annabeth Brown. Welcome to the North Carolina Learning Collective webinar series. Today, we will be hearing a webinar on motivational interviewing, improving medication adherence. And we are just delighted to have Dr. Glenda Wren presenting for us today. Dr. Wren is an associate professor, psychiatrist, and health policy mental health services researcher at Morehouse School of Medicine, where she directs the Division of Behavioral Health in the Satcher Health Fellowship Institute. And she serves as director of the Kennedy Satcher Center for Mental Health Equity. Dr. Wren's passion and overall research aim is to help create environments where individuals adversely impacted by trauma will face a path forward that makes it easier for them to recover and build a good life. Dr. Wren has helped to advance integration in several large health systems and individual practices of all sizes, and she serves as an advisor for several local, regional, and national health-related organizations. Thank you so much, Dr. Wren, and we'll just turn it over to you. If you have questions, you can type them in the chat box, and she will address your questions at the end of the webinar.
Thanks. And at the end, if you could read the questions to me, since I don't see the chat box from my view, that would be great. Well, good afternoon, everyone. Yes, we have a short time together, but I'm really excited to share with you hopefully a framework for motivational interviewing that you can use in your everyday practice. All of you that are taking care of patients, no matter what your role is, are probably faced with the challenge of people adherence to the treatment recommendations. And so this is, I think, the most broad application of motivational interviewing for clinical audiences. So at the end of the webinar, you'll be able to identify the core principles of motivational interviewing, understand the nature of medication non-adherence and how MI applies to this problem, and use motivational interviewing techniques to improve patient interest in medications and aligning provider and patient expectations. Now, this is just an introduction to motivational interviewing. I highly recommend that those of you that are interested get additional training. You can't teach someone how to actually do MI in the time that we have today. In summary, though, Romick and Miller back in 1995 developed motivational interviewing as a directive client-centered counseling style to help promote behavioral change by helping individuals explore and resolve their ambivalence. This is really important because often this is left out of the clinical encounter, and then patients are faced to deal with this on their own, usually not with the benefit of discussing with their clinicians. So first, the principles were described back in the 80s, and there was really a focus on the spirit or philosophy of MI and behavioral change as the important aspect of the approach. And it really focuses on practical tools that you can use with patients. The most important theoretical concepts are that this is about the relationship, and the relational component that's of importance is empathy and the interpersonal nature. There's also a technical component that has to do with the steps of how do you evoke the differences that people are experiencing, and how do you develop and reinforce change talk amongst your clients. So it's grounded in the trans-theoretical model of change that focuses on the stages of change, which you recognize that wheelhouse to the left. That's about pre-contemplation, contemplation, preparation, action, maintenance, and relapse. And the goal of any type of interaction is to move people along that cycle of change. If they come in pre-contemplative, can you move them up to contemplative? Can you problem solve around things that they might experience that would bring them back to an earlier stage? So the overall principles here are empathy, that's very important. How do you show warmth? How do you support the patient? How do you develop that discrepancy? How do you bring that into the view between the provider and the patient to expose the aspects that are going to be important to change? And if you don't remember anything else, roll with resistance is something you should embed into your mind because resistance is really an important predictor for outcomes. And most we'll talk about that in a little bit about how your instinct is going to be to kind of push back, but in fact you want to roll, you want to lean into the resistance in order to engage the individual and then look at the problem on the same side as opposed to being an oppositional side. And then you really
Dr.
want
Wren.
to develop, oh yes.
I'm so sorry to interrupt you, but folks are having a hard time hearing because I think the music is getting picked up through your headset. Did you switch to a headset?
Let me switch back. Hold on.
Yeah, if you could maybe just speak more directly into your
Is that better?
microphone. Oh, yeah, that's so much better. I think the headset was just picking up all that background noise. I'm so sorry, but yeah, that's much better. Thank you.
Thank you for the feedback. Okay, so rolling with resistance is the most important aspect so that you can lean into the resistance that the individual is bringing and look at the problem together on the same side as opposed to being on opposite sides. And then another really important aspect is the support for self-advocacy. You want to ask questions, to reflect out loud, to help the individual believe that they can change. Sorry for the train. So what are we talking about in terms of medication? This graphic is like, dude, you're over-medicated. And if pill bottles could talk, they would tell you a really interesting story about what's actually happening with patients. Bottom line here is that patients don't take their medication. There have been so many studies that have found that patients with chronic diseases only take their medications about 50 to 60% of the time. And whether or not they're adhering to their medications, a third of the patients that have chronic disease have strong reservations about the medications they're taking. So we could categorize them as being at risk for discontinuation. There was actually, some people think, oh, this is just important for medications that, aren't that, life-altering or important for, safety reasons. But there was actually a study of elderly patients, and I'm going to be moving outside of the train noise. There was a study of elderly patients that showed that patients taking digoxin only took their medications, they only had access to digoxin 30% of the time. So that means that they weren't refilling their medications in a frequency that would even allow them to be adherent to the recommendation. So that's, digoxin is a pretty important medication for people to take, yet they're not taking it. If you want to shift into antidepressants, it's even worse. So 60% of primary care patients stopped taking their antidepressants before they completed their 6-month course. So what do we know about non-adherence? Everyone does it. Most of us are actually guilty of it. It's associated with treatment failure, with poor outcomes, and we know that patients may also try to catch up with their medications and become compliant shortly before their follow-up appointments. So even if you're taking a medication that you have to monitor with serum levels, that might not tell the truth about adherence. So even if you have someone on lithium, that still may not tell the story. So here you have a graphic of a patient that says, right now I take a blue pill, a purple pill, an orange pill, a white pill, and a yellow pill, and I need you to prescribe a green pill to complete my collection. We think our patients are, even the ones that we think are adherent to medications, we want them to aspire to be that way, and the question is, why aren't they? So the nature of non-adherence, we often focus on the red box, that people just don't want to take their medications. But in fact, there's a couple of other really important routes. Oftentimes people can be confused over the directions that they're given. They may have external limitations that you're not aware of, such as trouble with their co-pays, transportation to pick up their medications, or even cognitive problems like dementia or just generalized forgetfulness. And so let's talk about resistance. So resistance is when the patient isn't doing what you want and you're not doing what the patient wants. It's a two-way street. And it's not a behavior that one person does. Rather, it's an experience that two people share, and both parties are unhappy. There's an intense push on one side, and if you're not mindful, there'll be an intense natural pushback on the other side. Regardless of the intensity of resistance, when one person yields even just a bit, resistance often resolves. And that's the counterintuitive aspect of resistance, which is why we talk about rolling with it. So why should you roll with resistance when it comes to medication adherence? Well, what drives the intensity of our patients' resistance is not how much we are truly opposing them or pressuring them, but their perception that we are doing so. That's really important. So the patient's perception is not created so much by what we say to them, but how we say it. And, you know, we know that it's true you can hold opposing views from your patients without being oppositional, depending on the words that we use to share those views. The key here is that your words are going to convey the relationship, and the nature of the relationship that you want to have with your patients is of shared decision making, of being on the same side, of moving towards the same goals, not forcing them to do something that they don't want to do or they can't do. So how can we think about medications? Well, the process of choosing to put a foreign substance into your body is a deeply personal one. And understandably, if you think about your own experience with adherence, you probably can use that data to try to look at this from your patient's perspective. And it requires 3 aspects of the choice triad to be green. The first one is that you feel something is wrong with you. No one's going to take a medication for a problem they don't think they have. Secondly, you have to have some type of motivation to try to get help with that problem through the use of medication. And thirdly, you have to have a belief that the pros of taking the medications will, in the long run, outweigh the cons. There's always going to be risks and benefits, but you're not going to actually take the medication unless you think that the pros are going to outweigh the cons. So what does this look like in real life? Well, here's a couple of examples. The first one is a 25-year-old patient with a first break of psychosis that doesn't believe there's anything wrong with them. You can't really move forward in a conversation about medications if that individual is still focused on not having a problem at all. So you have to find some type of way, and in this case, maybe you're connecting on a problem that they're having, like you can't continue in school. Okay, well, how can we incorporate medications as solving that problem that they agree is there when they may not be as interested in that understanding of the problem as related to psychosis? But from primary care settings, here's a very common example of a middle-aged woman that doesn't have a lot of symptoms except for unusually frequent daytime urination, nighttime awakenings with trips to the bathroom, and a recent onset of feeling weary. And that person might be overweight and not very well in terms of their fitness, but then when they come in, their blood sugar suggests that they're really on the track to get diabetes, and you know, she needs to engage in a diet and exercise plan, and maybe considering even taking an oral hypoglycemic depending on her risk factors. Now, this is a person that, depending on their pre-existing beliefs about medications and the fact that they feel all right, that's going to really be something you have to address and not kind of breeze through that in the context of making recommendations. So what can you do? Your role here is to help the patient become better informed and motivated for change. And what helps is to change your perception by recognizing that the patient is making a completely logical choice based off of their perception and beliefs. You kind of just have to convince yourself from the starting point that the choice that they're making makes sense. And if you don't understand how it makes sense to them, that's something you want to find out. Because patients take their medications because of what they believe, not because of what we believe. So how can you help motivate someone? The first one I call inquiry into lost dreams. Oftentimes, patients are not always focused on relief from something that their illness has given them, like symptoms, rather than they want something back that the illness has taken from them, like peace of mind or their livelihood or longevity, dreams that they have of their future. And this motivation can be very powerful in helping a patient to overcome side effects of medications, the inconvenience of the frequency of the medications, or even the stigma of taking medication. So refocusing them on not like this is important so you can not have these symptoms, but what are the things that you want to do, what are the things you want to have, and that's where the medications have their role. And so the question you can have here is there anything that your diabetes is keeping you from doing that you really wish you could do again? And that would be the start of the conversation around medication. The second really powerful motivation is family. It's really important to become familiar with the patient's unique family history, their network, and their connections to individuals in their family, and their sense of familial responsibilities. We usually do this anyway in clinical practice, but the important thing is to use that information to develop an individualized strategy for motivating the patient, very individual and specific to them. So these are just some examples. The patient kind of says to themselves, this one is for my daughter every time they reach for their medication bottle. And that was something that was very powerful and motivating to them. Or another example of a patient that puts a picture of their family on their cigarette pack to remind themselves of the reasons that they're trying to quit. When I'm working with patients, I kind of throw a couple examples out there based off of what I know, but then I encourage them to make it their own. And a lot of the idiosyncratic solutions that they come up with really resonate with them. Just last week, I had a person who says that they have their hands in their pocket all the time. And so what helps them to take their medications is to wrap their pills in a piece of tissue and put it in their pocket. And that doesn't seem like the greatest idea to me, but I was like, okay, like somehow you think that's going to work for you. Let's go with that and see what happens. Another one that's really important when you're having this conversation is our language. This title is around non-adherence because that's usually a clinical term that we use, or non-compliance, but it really is a failure when it comes to a way to communicate with patients. Non-adherence is basically just a PC version of non-compliance. No one wants to feel non-compliant. It also presumes that the physician is in control of making treatment recommendations and that the patient's job is to comply or adhere to the plan. That's not the dynamic that you want to set up. And only a small percentage of patients are purposefully oppositional. The term doesn't really distinguish between the reasons for non-adherence. There's no easy way for you to talk with your patient about treatment adherence without setting up a fight. So what do I say you should do instead? Talk about medication interest. I now use this language in talking with patients and even in my documentation so that I can have consistency. And here's just a little script as an example of how you might use this in conversation. So my goal is to always give you the best advice, whether that advice is to start a medication, to stay on it, or get off of it. And together we want to find a medication that you're genuinely interested in taking because it makes you feel better. You're the one that's putting the medication into your body, so it's your opinion that's most important, not mine. So please always let me know exactly what you think about the medications that we're trying. I need your input. You know your body better than I do, and I think we can be a great team. And finding a medication that works well for you that makes you feel better. And these kind of bits of language about you're in charge, you're putting it into your body, I need the information that you have, I use that really consistently, especially with new patients, but even with patients that I've been treating for a while. So the questions you should ask yourself in starting out: how interested is the patient in taking the medication? Usually you can tell. They start out with like, I'm not that into medications. They're telling you up front, okay, we're going to have to find another way. And then if it's a patient that you're now thinking about, oh my gosh, I've never asked this before with my patients, next time they come in, what % of the dose do you think they're taking? Like, it's probably not 100. So what do you really think they're taking percentage-wise? And then how do they list the pros and cons that might be leading to their low interest? What's really bothering them about the medication? A lot of my patients just hate opening pill bottles. It reminds them that they're sick. And I say, you know, I know this might seem like a really old lady thing to do, but you need to get like a pill box for the week and fill it up one time a week, and then you don't have to think about it every day. Or get a really beautiful little pill container to put in your pocket so at least you can look at something pretty when you're taking your medications out if you're in public. And that has really helped a lot of patients that had never thought about how much of a deterrent it is for them to open up every single pill bottle and take their medications. They just will like stop taking some of them just because they don't feel like taking another pill that day. The other thing that you can ask yourself is, going back to that choice triad, which step of that triad is their low interest related to? That will help you focus your conversation. And what ideas do you have about how you can increase their interest, and what about their family? How interested are they? And if they're a barrier, how can you engage them and address some of those issues so that you're not constantly fighting against them? So another really important topic in this context is about medication sensitivity. So here's the key question. Mrs. Jenkins, do you think you're particularly sensitive to medication? What are some of the things that you've seen in the past with medications that show that you're oversensitive? Now, you probably already know what this means. Everyone has a patient who, like, they're allergic to everything. They can't tolerate everything. Everything's on the list of things they've tried that can't work. And Probably it has something to do with the fact that they're really sensitive to the side effects of medications, and the prescribers haven't been attuned to that. And there are many effective strategies of working with patients who are this way. First of all, do not challenge their perception. You want to talk about the common side effects and engage them about how to minimize them if it's possible. What I often do is start them off with a baby dose, and I will even use language like, this is half of a dose of what we would give a 5-year-old child. And I'm starting you on this dose because I know you're really sensitive to medications. Your body needs to get used to it. You need to give it a chance and not judge it for the first 2 weeks. And unless it feels just like you're bedridden, and if that's the case, I need you to call me so I can tell you whether you should write it out or we can agree that you should stop it. That might sound extreme, but it's better to go through that up front than to just have someone keep failing, quote unquote, failing medications when they really haven't given it an adequate trial. They haven't been able to get to a therapeutic dose. So what I also like to do with patients like this, and really everyone, is give them control to self-titrate. Many of the medications don't require strict titration strategies. So I kind of write out some options and giving them control to say, if you feel like you can get up to, this higher dose before you come back, go ahead. If you're not sure, you're not feeling that great, just stick on the low dose and then we'll talk about it when you come back. So what about when people choose to stop their medications? You need to be thinking about the belief sets around efficacy. Do they just not think it's working? Oftentimes people stop it and you wouldn't have expected a response because they're not on a therapeutic dose, but they're like, it's not working. So talking up front about, hey, I'm starting on this dose, this is not a therapeutic dose, I would not expect for you to feel significantly better until you were on this dose. That helps to get patients with like an accurate expectation. Cost is a big thing we often don't think about at the top of our mind. You want to be able to have that conversation with them. The third area is around the psychological meaning of the medication and what does it mean to them when they're taking the pill. And so when people coming in follow up, I ask them, at this point, do you think you're on too little, too much, or just the right amount of medication? And that is a non-judgmental way of starting that conversation. When we think about efficacy, that might be different from how the patient thinks about it. You always want to invite the patient to tell you the pros and the cons, instill positive expectations, and the 1 to 2 week phone med check, if you have nursing staff that can call and be proactive, the patients are like so grateful. Oh, thank you so much for checking in on me. Oh, everything's going well, or it can tell you up front that things aren't going well. And you want to find out why they think it's not working. So many individuals have attribution errors where they've like done all this other random stuff. And I'm like, do you think that your side effect might have something to do with the fact that you mentioned drinking 20 cups of coffee every day? And they're like, oh, I never thought about that. So you've really got to try to understand like what else has been happening differently over the time that you started this medication. Or what I like to do is try to help them to not do too many different things so that we can make sure we properly attribute anything to the medication. They have a tendency to bias bad things towards the medication and success towards, well, I'm drinking more water and that's why I'm better. You also want to have genuine concern about the side effects. You want to go into detail about them to say, walk me through a specific time that you experienced this side effect. Let me know what it was like for you. You want to get them to give you a severity rating. How bad was it? And probe for impending discontinuance. This is another kind of really important trick, and that is to proactively recommend discontinuance. Think about it. The person's going to stop taking the medication anyway. You might as well bank some positive points by saying, you know what, this medication probably doesn't sound like it's a good fit for you. I think you should just stop it. And when you're able to do that before the patient's actually told you that they've stopped it already, then you gain trust with them. And you don't lose anything because they weren't going to take it anyway. So it's like a win-win. What about the costs and benefits? So there's some hidden costs that I wanted to point out to you. The first is inconvenience. And this can be as simple as calling in the prescription to minimize inconvenience rather than having them, go and wait in the pharmacy. But also, short-circuiting that shame cycle. And the easiest way, and the most common issue around shame is when they didn't take the medication. They know they're supposed to take the medication, but so you want to normalize the missed doses. Hey, did you notice any problems with the doses being inconvenient or find yourself missing any of them? So I never ask, like, how are you doing with your meds? That's like a horrible question because, I mean, they're just going to give you what they think you want to hear. So I always say, like, hey, tell me about your experience. Any problems with the doses? Like, you know, they didn't work out for you in terms of the timing, or something happened where you just like found out that you missed a dose? And then you also want to explore workplace stigmatization, or just being out in the community or whatever they're doing, having to take medications if they're like 3 times a day or dose in the middle of the day, and give them tips on how to minimize, whether that's a nice pill box or going in the bathroom and taking your medications. I mean, it seems like a small thing, but these are reasons why people don't take their medications. They can't think about a way around it. And then negotiating a short-term contract. The language I use is like, I'm not asking you to marry this medication. This is not a lifelong commitment. Let's try to ride it out for a couple of weeks and see if this is going to be the right one for you. But, you know, I don't live or die over any one medication. There's many of other options, and we should explore them together. And then that's the other thing is if they're interested in alternative treatments, you should express an interest in that because they're going to take it anyway. You might as well have them tell you about it. Okay, so what about the soul of the pill? This is really important because this speaks to what the patient feels it says about them that they have to take that medication. You want to really search for those demoralizing tapes and change them with positive affirmations that resonate with the individual. These are just some examples of ones that my patients have kind of come up with on their own. They have meaning to them. They kind of pass their gut check, and it helps them to overcome the negative initial reaction. I say you can't help your first and second thought. Those might be negative, but you can choose what your third and fourth and fifth thought is. So let's talk about what you're going to do once you find yourself saying, I don't feel like taking my meds today. You also want to dismantle any addiction myths. A lot of times medications that aren't addictive, just in general, people think, like, I don't want to have to live by a pill. Okay, we need to start telling ourselves another story about this medication. Or the crutch myth, like, you're not weak because you have to take medications. Like, you know, your pancreas didn't do anything wrong. You need this medication. It's part of optimizing your well-being and helping you to be there for your family. That's when you circle back to those motivators. And you want to create a plan for testing the waters because, again, patients, if they feel strongly about not wanting medications, you need to give them a framework of how they can do that with you. So getting a read on their grapevine is important too, and their support network or their friends' opinions. Just ask them, anyone in your family take this medication? What was their experience? You want to maximize the placebo effect and minimize the nocebo effect. What about new medications? So you want to ask their recommendations. You have a medication that you want to take. What do you think might help with your symptoms? And you want to directly uncover the ambivalence. What are your thoughts about taking up this medication? And now that we've talked about the benefits and side effects, what are your thoughts? Do you think it's worth a try? What's most appealing to you about trying this med? What concerns that you have? And throughout that conversation, don't push the initial decision. Oftentimes, what I do here is I kind of say, well, you know, let me just give you this script. That way, if you decide you want to fill it, you can. If not, that's fine. But I don't want you to go like in a month and, you know, change your mind a week from now, and then you just have to wait to get better. And so that kind of normalizes if they don't fill it, which a lot of times they're not going to do that anyway. So just to summarize the techniques as we're wrapping up, you want to ask permission always, have open-ended questions where you can, help to elicit affirmations, demonstrate reflective listening. You want to elicit the response that they're likely to have and summarize what you've discussed together. Make sure you haven't missed anything. Key takeaways from today: don't be an ostrich about medication administration of your patients. Think about medication interests. Start to use that language with yourself and with your patients. And practice those interviewing tips that I have listed for you today to help you explore and improve the medication adherence of your patients. And finally, roll with resistance and be honest about your own contributions to the issues with your patients. So I think I'm right at 129, and Anna, if you can read off any questions that have come through, maybe I can take the last minute and answer them.
Thank you so much. No, I don't see any questions in the chat box, so audience, if you do have a question, feel free to type it in the chat, and Dr. Wren will be glad to to address your question. I just thought that was so fascinating, and it was so interesting how it all comes down to relationship and communication, right?
Yeah.
Wow, but it's so nice to hear a doctor say that. I think so often we feel like, doctors are not going to have time to talk to us about these issues, but you're right. Going on medication is a very big deal for most people.
It is, and if you don't take the time up front, you're just going to have the problem longer. And I always talk about this with primary care doctors, always press the time. It's like, you just choose when you're spending the time, and the upfront time helps you to get the outcome that you want. Ignoring the time issue, it's just going to be that patient that's coming back, hospitalized, fighting with them, and they're not getting better. So I always make a point to invest the time up front when the patient's new to me, so that it can be smooth sailing the rest of the way working with them.
Absolutely, and then your patient is going to feel like you care about them, and so they'll probably give you more information so you can provide better care, and they will do, better too, because they'll be more invested in getting better. So thank you. You had so many really great points, and I realized we did not title this webinar correctly by including the term medication adherence in there. We should have said medication interest.
Well, you got to start where people are and move to where you'd like them to be. So everyone is like, what's medication interest, right?
Well,
and,
our time
feel free to send out, you can send out the PDFs to all the participants also. So I didn't know if anyone was wondering about that. Yeah.
Well, thank you very much. That's very kind. A lot of times people do want the slides so they can kind of pour over them. We are recording this webinar, and we'll post it on Start With Your Heart, our website. And thank you so very much. This was fascinating. I know everybody agrees that we all learned lots today. Thank you so much.
Annabeth,
my pleasure.
There have been a couple questions that came in.
Okay.
Kiana says, are there any recommended resources for additional training on MI, medication interest? And Latanya says, can we go back to the frame that has a quick reference of takeaway or things to remember? So those are the things that showed up on the question panel.
Well, probably that last question, if we can just send out the slides to everyone, they can pore over them and look into them as they like. And in terms of additional training for motivational interviewing, there's probably a training resource close to you where you can get training depending on your discipline, whether it's primary care, there's specific trainings for that, or behavioral health. So if you just actually Google motivational interviewing training, there's a couple of very common institutes that come up high up on the Google search, and there's online options as well as in-person trainings and books too if you want to learn from reading that way.
Great, so lots of resources. Fabulous. Well, thank you so much, and thanks everyone for participating.
Many thank yous.
All right, bye.
Thank you, Dr. Wren. Bye-bye.